being presented by Jeff Bromscheiber and Jeff Johnson, partners in the healthcare consulting practice of Whitley, LLP, a Wisconsin-based CPA and consulting firm. Rural Health Clinic 101 is intended to provide a general description of the program for those unfamiliar with rural health clinics. This 45-minute presentation is comprised of 5 components, ranging from a general overview of the Rural Health Clinic program to a more detailed comparison using available benchmark data derived from Medicare Rural Health Clinic cost report submissions. This is Jeff Bromscheiber, and I'm joined by my colleague Jeff Johnson. I'll be leading the discussion, and Jeff will be commenting throughout the presentation. If we do our jobs correctly, by the end of this webinar, you should have become introduced to the Rural Health Clinic program requirements. You should be able to recognize the process a clinic must complete in order to obtain Rural Health Clinic certification. You should become aware of the financial and reimbursement implications of Rural Health Clinic billing and payment, and you should understand some of the available comparative data that can be extracted from Rural Health Clinic cost report filings. Included at the end of the presentation documents are key reference materials as well as contact information that you may use if you require additional information about this unique program. So what is a rural health clinic? Well, rural health clinic certification is a voluntary designation received from the Centers for Medicare and Medicaid Services, or CMS, that's awarded to clinics who provide primary care services in certain rural, underserved areas. And as a rural health clinic, these organizations receive or can receive an alternative cost-based reimbursement system for treating Medicare and Medicaid beneficiaries. Rural health clinics were established by law in 1977 under Public Law 95-210. In that law, there was an amendment to the Social Security Act which added the ability to extend Medicare and Medicaid coverage for payment of services provided at rural health clinics by physicians, nurse practitioners, physician assistants, certified nurse midwives, and other non-physician practitioners. This was an important piece of legislation since there were no other areas or no other places of service where these non-physician practitioners could provide services without the direct supervision of a physician and receive reimbursement by Medicare and Medicaid for those services. So it really was the beginning of the use of non-physician practitioners in locations that formerly had not been authorized for the payment for those services provided by those level of practitioners. It authorized the payment not only for just for those provider types, but then also offered a unique reimbursement mechanism that was based on cost of the services provided as opposed to the more traditional fee-for-service reimbursement mechanism. The Rural Health Clinic law, among a number of other requirements, but stated that those clinics had to be located in an area that was designated by the U.S. Census Bureau as non-urbanized or rural, as well as the areas had to have been designated and certified by the Health Resources Services Administration as a shortage area. In the beginning, the program included a grandfather clause that allowed for the continuation of the rural health clinic designation well after or even after the area no longer was considered a shortage area or even a rural area. Now we'll talk a little bit about this in the as we go through the presentation, but that grandfather clause is no longer included in regulations for the rural health clinic program, so that currently rural health clinics are not guaranteed continued certification or designation in the event that their areas are no longer considered rural or no longer considered shortage areas. The program participation started off quite slowly, but it grew significantly in popularity in the early 1990s or so. My first exposure to the Rural Health Clinic program was in 1991, and at that time in the state of Wisconsin there were only, I believe, 2 certified rural health clinics in 1991. Today there are over 4,000 certified rural health clinics throughout the United States. As we go through, and we'll talk about this in greater detail, but it's important to recognize that also that there are 2 different types of rural health clinics. One type is considered an independent rural health clinic, and those are typically owned and operated by private physician practices, not necessarily owned or operated by another institutional provider such as a hospital. So there are independent rural health clinics. Predominantly at the beginning, those rural health clinics were all independent, or for the most part were independent. However, since the mid-1990s or so, we've seen an increase in the number of rural health clinics that are affiliated or owned and operated by hospitals. And therefore, the second type of rural health clinic is considered the provider-based rural health clinic. Currently, almost half of the rural health clinics in the country are provider-based to hospitals, and predominantly those hospitals are rural critical access hospitals. However, there are a number of provider-based rural health clinics to larger hospitals or hospital systems, and provider-based RHCs can be part of a skilled nursing facility or even a home health agency. I don't know, Jeff, have you had any experience or seen any rural health clinics that are part of a skilled nursing facility or a home health? I have not.
Neither have I, Jeff. And although we are looking at creating one as part of a nursing home, skilled nursing facility in the near future.
Okay. I think predominantly the provider-based RHCs are housed or owned and operated by hospitals, but it's just important to recognize that there are these 2 different types, and they are treated a bit differently when it comes to the reimbursement system, as we'll explain in greater detail. In terms of the total number of rural health clinics, if you look at this chart, there were less than 500 RHCs in 1989. That has changed dramatically, as we had indicated. There are currently over 4,000 rural health clinics. And the breakdown by state shows that the state with the largest number of rural health clinics, the state of Missouri, grew from just 2 rural health clinics in '89 to 380 rural health clinics in 2014. Currently in the state of Wisconsin, we also had 2 RHCs in 1989. The current numbers are at 65 certified rural health clinics in the state of Wisconsin. As I mentioned previously, there are 2 different types of rural health clinics, the provider-based as well as the independents. There is a distinct reimbursement advantage for provider-based rural health clinics, especially those that are part of a small, under a 50-bed hospital. When we look at the differences in reimbursement between traditional Medicare and Medicaid reimbursement as a non-rural health clinic on a fee schedule basis and reimbursement that is cost-based as part of a small hospital, it's not uncommon to see fairly significant changes or increases in Medicare, Medicaid reimbursement for those provider-based rural health clinics over the traditional fee-for-service payment. And it's, like I said, it's not unusual to see fairly significant changes in reimbursement for clinics who become RHCs. We've seen certainly examples of 80 to 100% increases in Medicare and Medicaid reimbursement for those clinics who became rural health clinics. Independent RHCs, on the other hand, while they may see an increase in reimbursement, it's not typically as high as the provider-based RHCs because the independent RHCs are held to a maximum reimbursement rate for Medicare as well as Medicaid in most states. That maximum reimbursement rate for 2014 is about $80. It's $79.80 per encounter, so, which is not a whole lot different than what traditional fee-for-service Medicare reimbursement averages on a per encounter level. So independent RHCs, while there may still be a benefit from a reimbursement perspective, that benefit is often in the form of higher Medicaid reimbursement as opposed to Medicare reimbursement. All right, in our next segment, we're going to talk a little bit about the requirements or the qualifications for a rural health clinic. And if we revisit that definition of a rural health clinic, again, the certification, it's a voluntary designation that certain clinics who qualify can apply for and receive. And those clinics who qualify need to be providing essentially primary care services in certain rural underserved areas. And if they meet the requirements and pass the certification, they are entitled to receiving an alternative cost-based reimbursement system for treating Medicare and Medicaid beneficiaries. And we're going to talk a little bit about each of those various qualifications or requirements. The first requirement on slide 11 has to do with the types of services that are provided within the context of the rural health clinic. And we commonly state that those services need to be primarily primary care service, meaning a majority of the services provided by the clinic are for the treatment of acute or chronic medical problems that usually bring a patient to a physician's office. Now, when we say the majority, the requirements have held that basically over 50% of the services need to be considered these types of services, the primary care type definition of services that would bring a patient to a physician office. It doesn't mean that the clinic or that a rural health clinic can't provide specialty care services within the context of a rural health clinic. And in fact, many rural health clinics do provide some level of specialty care. It's not unusual to find rural health clinics that may have general surgeons or orthopedic surgeons or urologists as part of their overall rural health clinic. However, they need to, in order to remain qualified and obtain qualification as a rural health clinic, they need to be primarily providing that primary care service. The second qualification is that the clinic needs to be located in what is considered a rural area. Now, a rural area designation is really just an exception to what would be considered an urban area. So one way to define rural is that it's an area that is not considered an urban area as defined by the U.S. Census Bureau. If you're not sure as to whether your particular area is considered a rural area, there are tools available on the internet that can help you define that. The Rural Assistance Center has an online application called Am I Rural, and it allows you to put in the exact address of a particular clinic, for example, and it will tell you if that particular area is considered rural for rural health clinic designation purposes. It's a very handy tool. There is a reference at the back of the presentation materials for the Rural Assistance Center, but it's a fairly easy application to confirm if any particular area that you're interested in is considered rural and or according to the U.S. Census Bureau. The third qualification we talked about, in addition to the primarily providing primary care services and the rural designation, is what's considered an underserved area. In order for a clinic to be designated a rural health clinic, it has to be physically located in one of the following underserved area designations. The first three designations that we've listed here on page 12 are federally designated health professional shortage areas, or shortage areas considered either health professional shortage or medically underserved areas. And those are two different federal distinctions that could apply for rural health clinic status. The geographic health professional shortage area is just as what it states. It is a certain geography, which could be an entire county, it could be a fraction of a county, it could be a service area that has been determined to have a shortage of health professionals, primary care health professionals in it. That HPSA status not only is used for rural health clinic purposes, but it's used for other grants and other federal funding directed at improving or increasing the supply of health professionals to a given geographic area. Again, at the end of the presentation, there are reference materials that allow one to access a listing, a database listing of all of the geographic health professional shortage areas in the country to determine if any one area in particular has a shortage area, current shortage area that applies. The population-based health professional shortage area is similar to the geographic HPSA. However, it is based on a determination that a certain segment of the population in that area is not adequately served by the given health professionals. In Wisconsin, we often see a population-based HPSA designated for the low-income population. For certain ethnic groups, we see it for the Amish population, for example. But even though that's the designation is population-based, the rural health clinic designation doesn't just require the RHC to provide services to that given population. So an area that has a valid and current population-based health professional shortage area is open to rural health clinic certification for the entire population of that area. The third shortage area designation we've identified here is called the medically underserved area, or MUA. That is also a federal designation. The criteria is a bit different than the health professional shortage area designation, but again, you can access the database on the HRSA, Health Resource Services Administration website. It will tell you if any particular area you are interested in has a valid and current medically underserved area designation. The MUA designation is a little bit older than the HPSA designation. It is not used as frequently by federal programs as the HPSA designation, but it still is a shortage area indicator that could qualify a particular geographic area that is eligible for RHC development. The last and the fourth designation that we've identified here are the governor designated shortage areas. And governor designated shortage areas apply on a statewide or a state basis. Not every state has elected to develop or identify governor designated shortage areas. Wisconsin is one of the states that has developed criteria for a state designation such as a governor designated shortage area. It also then opens the door for rural health clinic designation in a particular area by meeting the governor designated shortage areas. So in order for a clinic to become a rural health clinic, the particular location it resides has to have at least one of these four different shortage area designations apply to it. And that shortage area designation has to be current. Current being defined as updated within the last 4 years of the date of certification of the clinic. In the state of Wisconsin, I mentioned that the state has identified shortage area designations. This is a state designation. However, the state also was required to apply to the Federal Office of Shortage Designation in order to have their criteria approved. Wisconsin did that primarily as a result of the repeal of the grandfathering provision under the rural health clinic regulations. I mentioned previously, initially the rural health clinic regulations allowed for the continuation of a rural health clinic even after its shortage area designation had expired or was repealed. Subsequent to that, there was a change in some of the regulations that opened the door for decertification of clinics in the event that the area no longer was a designated shortage area. As a response to that repeal of the grandfather provision, many states then formed their own shortage area designation that could be used as a fallback, essentially as a safety net, in the event that the federal shortage area designation no longer applied to a given area. So when we look at the state of Wisconsin, for example, they have developed criteria that's been approved at the federal office, a shortage designation level, and that criteria is now used and applied across the state to identify rural areas that may not meet federal criteria but do meet the state designation. Each area that is approved for shortage area status at the state level is valid for 3 years from the initial date of the approval, and it can be used for then developing and retaining rural health clinic status in that particular location. We've included some of the criteria that the state of Wisconsin uses in terms of the physician to population ratio. There are 2 different levels of need identified. One is that the shortage area has a population to physician ratio greater than 2,400 to 1 physician, so a population of 2,400 individuals for every 1 physician full-time equivalent. A high need shortage area must have a population ratio of greater than 2,000 to 1 and meet at least one of the high need criteria in addition to the physician to population ratio. There's a number of different, and I'll just kind of scroll through the areas that have been designated by the state of Wisconsin for the governor's shortage area designation. You can see in some cases it's portions of counties, or in other cases it's the entire county. Door County, for example, it's the entire county of Door County, as opposed to some of these other counties where only sections of a county or certain service areas within a particular county may be designated as shortage areas. That list is being reviewed and updated on a continuous basis, and if you are located in an area that is not considered a state shortage area and you're interested in that designation, you can contact the primary care office at the Division of Health and Human Services of the state of Wisconsin and request a review of your particular area. We've got a web reference here on slide 18 that can be used for that information. As I mentioned, the underserved area designation has to be current, which means it's been updated within the last 4 years. Before a clinic proceeds with rural health clinic certification, that's one of the initial steps, is to verify that that area, it not only has a underserved area designation, but that that area, but that the designation has been updated within the last 4 years. And finally, if a clinic elects to go through the rural health clinic certification process and become a certified rural health clinic, it opens the door for an alternative reimbursement system for Medicare and Medicaid purposes that's based on an average cost per visit as opposed to the traditional fee-for-service reimbursement. Now, it's a little bit different mechanism for payment than traditional Medicare and Medicaid reimbursement, because traditionally Medicare and Medicaid was based on each particular service that is rendered to a beneficiary or covered by either Medicare or Medicaid. Under the rural health clinic cost-based reimbursement, the reimbursement is no longer based on the particular level of service, but is now based on a per visit amount, and a visit being defined as a medically necessary face-to-face encounter between a patient and a physician, a nurse practitioner, a certified nurse midwife, a clinical psychologist, or a clinical social worker. So as long as we have a medically necessary face-to-face encounter between a practitioner and a patient, there will be a billable service, and that billable service will be reimbursed based on the cost of the care provided. If there is no billable encounter or visit, there is no RHC payment, with some exceptions. Jeff, did you have anything to add on this?
I don't think so. I think that describes it well.
Okay. You know, there's always exceptions to every rule, but I think generally the per visit exceptions only apply to the flu and pneumococcal vaccines, where you actually can get cost-based, a clinic could get cost-based reimbursement, even though there is no billable encounter or billable visit. So just as a recap on slide 21, we said the clinic has to be located in a rural area. There are resources to determine if an area is considered rural. It has to have a current underserved designation. Again, there are resources available, and we've referenced them at the end of the document to identify whether or not a particular area is considered underserved. The clinic has to primarily be engaged in providing outpatient primary care services. Some additional qualifications, a mid-level practitioner or a non-physician practitioner, including a nurse midwife, nurse practitioner, or a physician assistant, must be present and available to provide services at least 50% of the time the clinic is open. And that's an important qualification because in the beginning of the program, it was designed to expand access to primary care services in rural underserved markets. And the primary method of expanding access was to open the door for these non-physician practitioners to be able to perform and provide primary care services without having the direct personal physician supervision that was previously required in order to receive Medicare and Medicaid reimbursement. It doesn't mean, however, that a physician is not involved in the rural health clinic operations, because an additional requirement is that a rural health clinic must operate under the medical direction of a physician. Until July of 2014, and I think it's actually July 11th of 2014, the medical direction of a physician required that a physician must be present at least once every 2 weeks on site at the rural health clinic. That once every 2 week on site requirement is being lifted in July of 2014, so that no longer does a physician have to be physically present at least once every 2 weeks. However, the clinic still must operate under the medical direction of a physician, and I would assume that most RHCs would require physician presence at some point in time. It's just not required once every 2 weeks after that regulation change. Some additional requirements. There is a requirement that a rural health clinic must be able to perform or must furnish at least 6 basic laboratory tests, and we've listed those 6 basic tests here in slide 22. The requirement is not that every patient who needs one of these 6 tests has to be performed within the rural health clinic. However, the rural health clinic must maintain its ability to perform each of these 6 basic lab tests at all times, and since the requirement states that a clinic must furnish these 6 basic lab tests, it's expected that the clinic will from time to time provide at least some of these 6 basic lab tests during the normal course of operations. There are several additional RHC qualifications and requirements that are referenced here on slide 23. We have referenced the regulatory sections for each of these requirements, and as you can see that there are a number of different components to each of the requirements, ranging from an overall requirement that the clinic comply with all federal, state, and local laws. That's the first one listed. 2, the location, which we talked about, and some additional requirements around the physical plant and environment, requirements around organizational structure, staffing, the provision of services, the maintenance and protection of health records, and finally an annual program evaluation. If you're interested in these what these specific requirements are, we've referenced the documentation that would provide you with further definitions around each of these requirements. As an example, however, we've pulled out one of the particular requirements around physical plant and environment, which is from the State Operations Manual Appendix G. G of that document states that under the physical plant and environment general standard, there is a requirement that the clinic have policies and procedures around non-medical emergencies. And these actually, this excerpt is actually the instructions for the survey agency who's conducting the Rural Health Clinic certification survey. And the instructions state that the surveyor should review the written documentation as well as interview clinic personnel to determine what their instructions are for the non-medical emergency procedures. So in order to meet that requirement for non-medical emergencies, the clinic is required to have written documentation as well as policies and procedures in order to demonstrate that their staff has been instructed around what to do in the event of a non-medical emergency such as tornado, hurricane, flood, or fire. And the surveyor will do a testing of the staff by doing interviews during their survey in order to determine whether or not the staff are compliant with this particular requirement. And this, again, is just one example of what you would find if you were to look at that Appendix G of the State Operations Manual that further explains each of the previous qualifications for a rural health clinic. So what does it take to become a rural health clinic? Here, just briefly, we've identified each of what we think are reasonable steps that a clinic would take in order to become a rural health clinic. We often get questioned as to how long does it take to go through this process. Well, it's highly variable depending on the organization as well as the surveying agency. I typically will say 6 months is a reasonable expectation to go through the certification process. Yes, it probably can be done quicker than that, but I've certainly seen instances where it's taken considerably longer than 6 months to complete the certification process for a particular clinic. One of the initial steps in looking at or pursuing rural health clinic certification is doing a financial analysis to determine if there would be a reimbursement benefit to becoming a certified rural health clinic. On slide 27, we've identified a sample, and it's a bit simplified, but it's a sample of what we would go through in terms of identifying what the potential reimbursement implications might be of becoming a rural health clinic. And quite simply, this example demonstrates that we would compare the traditional fee-for-service reimbursement rates with what the clinic could expect to receive under a cost-based system. In this example, we've compared the average reimbursement for just over 2,000, actually 2,080 rural health clinic encounters from Medicare that average about $70 of reimbursement per encounter based on the services being provided during those 2,080 encounters. We then compared that reimbursement to the maximum independent reimbursement rate for 2014 of $79.80. And what you'll see from an independent rural health clinic reimbursement difference, the change may not be that dramatic for Medicare purposes. Here we're only showing about a 14% increase in Medicare reimbursement, which translates into about $20,000 a year. Certainly not a small amount, but it's a relatively modest increase in Medicare reimbursement for the independent RHC. And one of the reasons why that that increase is relatively modest when you look at the independents is that the change in fee-for-service Medicare reimbursement for traditional office visits has actually been relatively healthy over the last 5 years. When we look here on slide 28, we're showing that in many instances, regular office visit reimbursement, the new and established patient evaluation and management services, have increased over the last 20 years for Medicare purposes by about 20%. And the maximum rural health clinic reimbursement rate over the last 5 years has increased less than 5%. So as changes have occurred in the traditional Medicare fee-for-service reimbursement system, those changes have resulted in higher reimbursement today than what historically had been in the past for the traditional services that are often provided by rural health clinics, in particular the independents. And since the independent reimbursement rate is a maximum amount of about $80 per visit, we find that independent RHCs do not necessarily benefit tremendously from a change in Medicare reimbursement going from fee-for-service to cost-based RHC, given the relatively modest changes in the maximum rural health clinic reimbursement rate. However, if you do the same type of an analysis for a provider-based rural health clinic, particularly one that is a provider-based to a hospital that's less than 50 beds, we find that because the hospitals that are less than 50 beds are not held to the same maximum limitations that the independent rural health clinics are, the reimbursement increase can be significantly greater. Here in this example, we're showing that, again, the average reimbursement rate per visit of about $70 for those same 2,080 visits. However, under the provider-based reimbursement rate, and we've used here as an example the average rural health clinic rate for provider-based RHCs across the country of almost $157 per encounter. If a rural health clinic is paid at that average rate of all other RHCs, the reimbursement change is substantially different than the independent RHC. Here we're showing an increase of 124%, going from an average payment per visit of $70 to an average payment per visit of almost $157. So again, there we've got a fairly significant increase in reimbursement for a clinic that becomes a provider-based rural health clinic to a hospital that's less than 50 beds. There are other considerations to make when faced with the decision to become a rural health clinic. Other payments that might occur under the traditional Medicare fee-for-service reimbursement, such as the health professional shortage area or physician scarcity area bonus payments. There may be costs, or there are costs, to comply with some of the RHC requirements. For example, that requirement that the clinic has to employ a non-physician practitioner at least 50% of the time that the clinic is open might mean that the clinic would need to go out and hire a non-physician practitioner or increase their staffing in order to meet that 50% requirement. Therefore, there may be an additional cost to the meeting that requirement. Certainly, there are costs associated with completing and going through the certification and survey process. There are costs associated with converting a billing process to rural health clinic billing, as well as the requirement that the clinic annually complete a Medicare and sometimes a Medicaid cost report. And finally, some of the costs associated with training and educating staff around the nuances of becoming a rural health clinic. So we strongly encourage any clinic who's interested in becoming a rural health clinic to evaluate not only the initial financial analysis, but some of these other factors that should be considered before making a switch to becoming a rural health clinic.
The only thing I would say, Jeff, is just to reiterate the fact that in your example we're talking about Medicare, but for the most part, I mean, as you pointed out, as for independents that are looking at maybe not affiliating with the hospital but want to get into the rural health clinic program, to really take a hard look at the Medicaid side of it, because that's where typically the benefit may be.
Oh, and that's a good point, because oftentimes, especially for the independents, that's probably the key to their decision is really on the Medicaid side.
And we also have some clinics that are maybe provider-based under a critical access hospital or a PPS hospital for that matter, which will be talked about in a different presentation. But when you're provider-based, sometimes the rural health clinic benefit may not be as big as provider-based in a kind of that, even in that small rural hospital, just because of the combination of the facility and the professional billing. But in the but again, the Medicaid may be much larger because many states don't recognize provider-based billing for clinics.
Right. For non-rural health clinics.
For non-rural health clinic services,
right.
Correct.
Right. Right. Okay, great. Thank you. With our time left here, we're going to talk briefly about some of the billing and payment nuances, and then we're going to explore some of the cost, comparative cost information real quickly. But from a billing and payment perspective, you know, I alluded to the fact that there was a difference, or there is a difference, between billing for rural health clinic services and traditional Medicare and Medicaid billing and reimbursement. The biggest change has to do with the fact that the reimbursement system moves from a payment for units of service, as defined by CPT codes, to payments per encounter, which is under an all-inclusive payment rate. So essentially all of the covered services that are provided during a particular encounter are included under that encounter rate, regardless of the level of practitioner that's treating that patient. So a physician service is reimbursed the same as a non-physician practitioner service under the rural health clinic methodology, which is quite different than under traditional fee-for-service methodology. There's also a difference on the actual claim format that's used. Rural health clinic services for Medicare purposes are billed under the CMS 1450 claim format, which is commonly referred to as the UB04 claim format. And the level of detail that's required is a bit different too. Traditional Medicare, Medicaid reimbursement is based on the CPT or HCPCS codes that are typically not even reported for Medicare RHC billing except for certain preventive services. So there is a very distinct difference between rural health clinic billing and non-RHC billing. We mentioned that the rural health clinics receive a cost-based reimbursement using a cost per visit methodology. That payment methodology is limited for the independent RHCs to $79.80 per visit in 2014. There is no such limitation for rural health clinics that are provider-based to hospitals that are less than 50 beds. Rural health clinics are not subject to a lower of cost or charge concept. It is possible that payment or reimbursement can actually be greater than what the charges were for that particular service. RHCs are required to complete a Medicare cost report and submit that within 5 months after the close of the cost reporting period on an annual basis. We mentioned RHCs are paid on that per visit rate, and that visit is defined as a face-to-face encounter between a patient and a practitioner. Therefore, if we have services rendered in which a face-to-face encounter does not occur, such as a nurse-only type service like checking blood pressure or administering an injection, if there's no encounter, that service is not separately billed or reimbursed under the RHC billing methodology. Just in general, from a rural health clinic billing perspective, RHC encounters are billed to either a fiscal intermediary or a Medicare contractor, like we said, on that UB04 form as opposed to a CMS 1500 form for non-RHC services. Any services provided incident to that particular visit, injections, supplies, are all combined with that rural health clinic visit, and there is no separate billing or payment for those incident to type services. Non-RHC services are billed outside of the scope of that per-visit limitation or that per-visit bundling concept, and those non-RHC services are typically billed to a Part B carrier or or perhaps even the fiscal intermediary or the Medicare contractor for that hospital-based clinic. The coverage does not change, however, so services that may not be Medicare or Medicaid covered as non-RHC continue to not be covered as a rural health clinic service, and in which case those services are billed to the particular patient themselves outside of their Medicare coverage. And finally, we mentioned real briefly initially that there is an exception for these flu and pneumococcal vaccines. In a rural health clinic setting, flu and pneumococcal vaccines are not separately billed, but are paid on a cost basis through reporting on the Medicare cost report. I want to walk through briefly an example of a claim that would be paid under the rural health clinic methodology. And if we had a particular visit, for example, where a customary charge was $100, under the rural health clinic methodology, Medicare coinsurance for that patient is based on 20% of the customary charge. So if we have a $100 visit charge under Medicare RHC billing and reimbursement principles, patient coinsurance is 20% or $20 for that particular encounter. Medicare, prior to sequestration anyway, will pay 80% of the encounter rate. So in this example, if our encounter rate was set at $80, which would be customary for most independent RHCs, Medicare would pay 80% of that $80 rate, or $64. So in this case, the total payment for that particular visit would be the combination of the patient coinsurance of $20 and the Medicare payment of 80% of the encounter rate, or the $64, for a total of $84 in this example. The difference between the charge and the total encounter, that difference of $16, is considered a contractual adjustment and would be written off or adjusted off of that patient account. Our final segment is really looking at some of the data that is available to rural health clinics that allows them to make some comparisons between the information on their rural health clinic cost report as well as cost reports submitted from other providers either across the country or on a regional or state basis. About a year and a half ago, CMS released cost report data that is now available to the public, and WIPFLE, in conjunction with the National Association of Rural Health Clinics, developed a benchmarking report that allows us to extract data from various cost reports and put together comparative information for participating rural health clinics. That data is based on the data set of CMS cost reports. Historically, or initially when we put this together, we had 2010, 2011, and 2012 cost report data. We are now beginning to receive 2013 data as well, so our comparative data can encompass each of those 4 years of information dating back to 2010. Some of the types of information that's available through the cost report are comparative data such as cost per encounter or cost per visit. And this is really the driver around the reimbursement rates. So I mentioned previously that the cost per visit, for example, across the country was just over $150 per encounter. You can see on the graph on the far right, we've got the national data both for independent RHCs shown in green as well as provider-based RHCs shown in gold, and that gold bar showing the average cost per encounter across the country for all of the provider-based RHCs in 2012 was just over $150 per encounter. Actually, that's quite a bit higher than the independent RHCs, who are showing just slightly higher than $100 per encounter across the country. We've also shown both Midwest regional data as well as the state of Wisconsin information, which is interesting to see the cost data in the state of Wisconsin being significantly higher than both the regional as well as the national data for the average cost per adjusted encounter for both independent as well as provider-based rural health clinics. So this is just one snapshot of some of the data that's available in the benchmarking tools that we have. The additional information available through cost reports shows, for example, productivity data, numbers of patients seen per physician as well as non-physician practitioners. Here we are presenting on slide 42 the comparative data for average number of patient encounters per full-time equivalent practitioner for both the independent as well as the provider-based rural health clinics on a state, on a regional basis, and on a national basis. Nationally, the average number of patients seen for provider-based RHCs is just over 4,000 patients per physician full-time equivalent. Independent RHCs are slightly over the 4,500 patient visits per physician full-time equivalent. And finally, the last data element we're going to show here is the productivity comparisons for non-physician practitioners, in particular physician assistants, the average number of encounters per physician assistant full-time equivalent, as well as nurse practitioner FTEs. And again, we show here comparative data on a state basis, a regional basis, and a national basis. So in conclusion, we believe that the rural health clinic program it can be a significant benefit to the communities in which these RHCs are located. Again, those communities tend to be rural underserved markets. The rural health clinic program itself allows for the increased access to primary care as well as behavioral health services in those rural underserved areas. The model is designed to leverage the scarce resource of primary care physicians in many of those locations by utilizing, to a greater extent, non-physician practitioners such as nurse practitioners, physician assistants, certified nurse midwives, clinical psychologists, and clinical social workers. In general terms, the Rural Health Clinic program provides for increased or enhanced reimbursement for Medicare and Medicaid services so that these providers can then afford to expand care and expand treatment to areas that previously had not had access to those types of care. So we do believe in many instances the Certified Rural Health Clinic program can be a real benefit to the communities in which they are located. I mentioned previously that we've got listings of additional sources of information as well as the contact information of both myself and Jeff Johnson if you should have any questions or comments about the information that was presented today. We thank you for listening to this presentation, and we appreciate all that you do in providing care to your communities. Thank you.